We have the very interesting talk coming up by our own scientific committee chairman, Dr. PARTHA BISWAS, who is going to be talking about the most important aspect of counseling and preoperative workup. It is often said that the more chat time you spend preoperatively, the less chat time you are going to be spending postoperatively. And this is perhaps the most important aspect for a satisfied patient at the end of the day. Over to you, Dr. Partha.
Thank you very much, sir. So, if I'm covering the most important topic of this session, do I have more time as well? So, suffice it to say that the need for premium IOL is spectacle independence and correction of astigmatism. And with this in point, let us look at the different pre-operative considerations. And if we look in detail onto the preoperative considerations, then we have happy patient and ultimately the happy doctor. The workup is very, very important, and small decisions at every step will ensure a good outcome. The patient's profile and first glance, exactly what Dr. Maipal just said, it is not that standard of his appearance or with the attitude which he speaks. It is important to give the value for every single thing that we have in our armamentarium, the lenses or the procedure for the surgery, so that the patient makes up his mind. So the age is important, profession is important, spectacles and lifestyle is important. And the history of the patient, usually the workup is done by our optometry colleagues, but let us look into the workup. Has it been detailed? Does it give you all the insights ultimately when you're going to offer this premium IOL for this patient? So the history of past trauma, laser intervention, a family history, a general health history, all that, has it been taken care of? And then the complaints of the diminution of vision, the irritation, watering, foreign body sensation, all these are important, and also that aspect about floaters is important. And we need to see during the pre-op checkup whether there is a PVD or not. And if it is there, that part has to go into counseling. Otherwise, a trifocal will be blamed that it has caused floaters in the eye after cataract surgery. Trauma is 100% important, laser intervention, and diabetic retinopathy, a past history of CRVO or BRVO, maculopathy, glaucoma. And if it is a patient with trauma, one has to be very, very careful. Of course, gonio and subluxation, all these have to go in. General health, and this I think we should impress upon our optometry colleagues or our juniors who are taking the history and doing the workup. Diabetic retinopathy, the chances of retinopathy have to be emphasized, and any patient with a stroke, antiplatelet agents, anybody who is on tamsulosin or antipsychotics, benzodiazepines, antihypertensives, everything needs to be determined while doing a preoperative workup. The vision and the refractive error, need for immediate or delayed surgery. At times the patient says, I'm not seeing very well, but the patient is reading 6.9 and the other eye is reading 6.6. So a patient with a 6.9 vision in a patient with a cataractous lens, do you think you would like to put in a trifocal and compete this post-operative trifocal with a 6.6 vision in the other eye? The patient all the time will be looking right to left and saying that, well, I think I still see quite well with the unoperated eye. So heavy dependence upon intermediate vision, night vision, where these come in are important, and the conversation should be a seamless conversation, but all the points should be noted. Low myopes who are excellently have unaided vision for the reading, and thereby you need to understand whether they would like to enjoy that reading vision without glasses. The degree of cataract, astigmatism. Astigmatism is a very important factor, and we need to look about the astigmatic profile of this patient. Ocular surface disease, the pupil size and the type of cataract, all very, very important while you're doing the examination. And an ocular surface disease has to be taken care of if it is there. The pupil size has to be noted. If it is a large pupil, you will have to tell the patient about the glares and halo that might occur. Corneal astigmatism, usually of 1.25 diopters, is more prevalent in approximately nearly 30% of eyes that have cataract surgery. Regular and irregular astigmatism, again, ones with irregular astigmatism are not good for multifocal intraocular lens implantation. And as we said, that dry eye and meibomian gland disease has to be treated before. The corneal dystrophies, and again, one should pay a little attention to the cornea on the evaluation. EBMD or Fuchs dystrophy are not very good candidates unless you can ascertain that this will not have a post-operative implication. The scars, pterygium, all these have to be taken into account. The pupil size, a large pupil, glare and dysfunction follows, and a small pupil is where the challenge while placing a multifocal IOL, and it may require pupil expansion. A decentered capsular axis is again a risk factor of a decentered IOL. So an eccentric pupil or an iris coloboma is again an absolute contraindication to a multifocal unless this patient has had a multifocal in the other eye and you have counseled enough and the patient does not have very good vision in this eye and still wants to go in for a multifocal if he has chosen with that choice. So the type of cataract, the grade, maturity, and again, if it is a mature cataract, a hypermature, where you have not been able to ascertain the fundus, you need to be very, very cautious while giving this patient a multifocal. You never know what disease lies behind, what is the status of the macula. And in PPC, it's good to avoid premium IOLs because it might need conversion. Again, an eye which has a PCR and you're operating on the second eye, you have to be very sure that if that eye has had a PCR by a colleague, this one could also be in the same line. Intraocular pressure, and this needs to be controlled, gonioscopy, a diagnosis of glaucoma. And if such patients are going to be considered for phaco-trab, again, a multifocal IOL is not the correct choice. Or even a trifocal, or even a multifocal or a trifocal, or a toric IOL might not be the correct choice because the cylinder and the axis might change. If it is a patient of glaucoma, the visual field status and the future, if required, of a shunt surgery has to be kept in mind. And checking for the AGM is very important, and the prostaglandins need to be changed in the immediate post-operative period. Dilated evaluation for lens subluxation and any retinal pathology or a need for a retinal laser in the periphery, all has to be determined. And a need for pre-operative OCT. Should you do a pre-operative OCT in every patient whom you have done a dilated fundus examination and you're happy with the fundus examination clinical? The answer is yes. Because in a fundus examination with a 90D or a 78D, or along with the indirect ophthalmoscopy, you will not be able to see traction on the macula, a taut PVD, or even a lamellar macular hole. So it is wise to do a pre-operative OCT in every patient with a premium IOL. Anti-VEGFs, of course, if required, it needs to be done. Sir, biometry, I think yes. So I'll just skip on the biometry. I'll not go to that. And keratometry. Topography also you're covering, no, sir? Topography you're covering? Topography you're covering, okay. So the angle alpha and the angle kappa and the spherical aberrations Dr. Ramurthy will be covering. So choosing the intraocular lens, and we have the monofocals and the premium IOLs. The premium IOLs may be a misnomer, is reserved for the multifocals, the torics and the accommodating IOLs. And of course we have the extended range of vision and the trifocals now in the market. And the aspheric IOLs with the negative spherical aberration and with minimum negative spherical aberrations are there, whereas the positive of which balances the positive aberration of the cornea, and we have the Acrisoft, the Technis and the Hoya Vivinex in this category. Now let us look at 3 or 4 situations, and here we have a patient, a 56-year-old lady, 56, I will not say old because I'm terming as a movie star, a 56-year lady, a movie star, but will get my cataract operated and I do not want to wear glasses. Is this what she says, the doctor? So we say, don't you worry, ma'am. And so this lady, of course, a trifocal would be something that would be required for her, and you have to counsel her, and she would accept any cause of glare and halo because her first criteria is to be off her glasses. Let's look at this next patient, a 48-year gentleman, an IT professional who loves to work out, doesn't mind glasses at home and not at work or while working out. So EDOF lenses are good for this patient. Patient C is a 68-year-old lady, a retired marine engineer, loves to travel and swim, likes his glasses while reading and gives a feel of pleasure while reading, and a high cylinder. So toric, yes. D, look at this diabetic lady who wore spectacles since childhood, and her friend got a cataract surgery done and doesn't wear glasses. She also doesn't want to wear glasses, and she's excited because she's retiring this year and wants to travel. Trifocal? No. So aspheric hydrophobic would be the right choice for her. A diabetic lady in her 60s would at possible some time develop diabetic retinopathy, would lose the goodness of vision. Last one. And patient E, a high cylinder post-RK, trifocal toric, no. Trifocal, no. Toric. Thank you very much for your patient hearing. Mics are not working.
Thank you for that excellent coverage, Dr. Partha. While I am setting up my slides, Dr. Ketyal, would you like to comment on what's the gap between 2 surgeries that you would allow between the 2 eyes? Because most often patients are more comfortable once they have been binocularly operated.
Yeah, thank you, Dr. Ramamurthy. Yes, I think that is a question have to be answered by us most of the time. Sometimes patient demand, sometimes they ask when should the other eye to be taken in. I think there are few important things to be considered before we jump for second eye surgery. First, the amount of refractive error in the other eye. Sometimes patient has a huge difference in 2 eyes, and patient as such will demand early surgery, and we should do early surgery for that particular case. And wait for a few days to see what is the outcome for the surgery of done in a primary eye. I think within a week or so, because by 1 week we stop the mydriatic most of the time. And that is the time the pupil comes to normal shape and size, and that will be the actual assessment from patient point of view also. So I would say it should be done as soon as possible if there is no contraindication, so that both eyes have a similar background. And we talk about neuroadaptation, that will be faster and patient will accept better. Sometimes in patient with a little bit of halos and glare, that might happen in the primary phase when the pupil little dilated, which also goes off and settle down very importantly. And binocular surgery, we have found that your binocular vision improves for distance, near, intermediate. And the stereo acuity also improves the binocular implantation. Those should be done as soon as feasible from patient point of view and from your point of view also with assessment.